the things they were really interested in was REM. This is around the time that REM was discovered. And they were so interested in REM because they thought this was a biomarker for psychoanalysis. Because you think about how much of it is looking at dream and dream contents. That's actually why they were so interested in sleep. And with the discovery of REM, which was just down the street at University of Chicago, this really gave them what they thought was going to be a biomarker for understanding psychoanalysis. Didn't quite turn out that way, but was very important for sleep medicine. But just so you understand, some of the roots, really, I would say a lot of the roots of sleep came from psychiatry. Over time, it's actually evolved into like pulmonology and neurology. Here, our sleep clinic and sleep center is actually housed under neurology. In a lot of other places, it's housed under pulmonary divisions and departments. So it's kind of expanded from there. The other thing I would say about sleep is there's a very close association between sleep and technology. So do you guys know who this guy is? Good, yeah. So why would Thomas Edison be related to sleep? Yeah, very good. Yeah, so with the invention of the light bulb, now, this created the opportunity to be able to have light, at times when we used to shut things down. So now this also gave rise to the Industrial Revolution. People could work around the clock, shift work, lots of things that started challenging our natural biological processes for sleep. Okay, how about these guys? Well, I guess it's actually written there, so it's kind of small, so maybe you can't see it in the back. So these are the Wright brothers. So how would they be related to sleep? There you go. Right. So, again, this is another thing where technology has really created a big biological challenge, right? So before we created jets, we couldn't travel fast enough across time zones to where we could create jet lag. So this is really a condition that's completely created from technology, right? So, something interesting to think about. So now into more modern things here. You guys know who this guy is. This guy doesn't need introductions, but now like with iPhones, with technology, we're always connected. We're a 24-hour society. More things that challenge our natural biological processes that regulate sleep and wake. So we have all these different things working against us. Now, I'm not one that's against technology, but what I do think is that we need to think through what technology can do, both in terms of how it can help us, but also where it might challenge our biological processes. And I think sleep is really one area where it does. All right. So just to sort of give you a scope here in terms of like the development of some other things in psychology and how it maps on with sleep. So, with the treatment of insomnia, it started in the 30s with Jacobson, with relaxation. This was one of the main treatments for insomnia. By the time the 70s and the 80s got here, this is when behavior therapy was at its peak, right? So things like sleep hygiene, stimulus control, sleep restriction, these are really very behaviorally oriented treatments for insomnia that really, sort of went along with the rise of behavior therapy. As we moved into the 90s, this is when cognitive behavior therapy started becoming popular. And so Cbt-I really was born. I think Charles Moore was really the key person here who developed Cbt-I. He combined a lot of Beck's cognitive approaches for depression, sort of adapted it for insomnia, and combined it with some of these other behavioral strategies that would really form the building blocks of CBT for insomnia. And then into the 2000s, this is where we started looking at, what is insomnia? How does it relate to other conditions? More research started coming out that if you treat the insomnia, you can actually improve the other comorbid condition. So the classic example is with depression. So there's now several research studies that have shown that if you give someone Cbt-I, for someone who has both insomnia and depression, you can actually improve the outcomes for depression. So treating one condition, in this case, a symptom or a comorbid condition can actually improve the outcomes of the other underlying condition. So it also kind of challenged how we thought about insomnia. It used to just be sort of a symptom, it wasn't really its own thing. But now we started thinking about, you can have an insomnia disorder that can be comorbid. And by treating that, you can actually improve, outcomes with other things. And I would say, now into the 2010s and beyond, we're moving into implementation science. So now that we have good treatments, it's all about how can you scale it, how can you deliver it, step care models, using the internet, app-based delivery. Again, bringing back technology, right? I can't get away from that. So, I think this does also kind of map onto a lot of the growth, in the broader field of psychology. So behavioral sleep medicine, just to offer a definition here, what is it? So it really, it's a field that focuses on the evaluation and treatment of sleep disorders by addressing behavioral, psychological, and physiological factors that interfere with sleep. So it is mostly grounded in the clinical domain. We do have a Society of Behavioral Sleep Medicine, so the SBSM we're a fairly small organization, and I say we, sort of taking possession here because I was actually the president of this organization last year, so I'm currently the immediate past president, which I would say is a much better position to be than the president. It's a lot less responsibility. So we're a relatively small society. We have about a little under 300 members, including students and clinicians. It is multidisciplinary, so the bulk of our members are psychologists, but we also have social workers, physicians, nurses. So it's kind of a fun group. And everyone there, is interested in behavioral sleep medicine. We do have researchers and clinicians and some educators as well. And so, it is a multidisciplinary field. I mentioned some of these folks. Now, within psychology, in 2014, so about 4 years ago, we did get sleep psychology established as a designated specialty by the APA. So even, among psychologists now, there is some movement to have an identity, within our community as well. Okay, so what does a sleep psychologist do? And I had this guy here because I think it's people like this that tend to come into my clinic, right? Someone who's like really trying to force sleep to happen but just can't make it happen. This to me is sort of the face of someone who has insomnia. So I would say, cognitive behavior therapy for insomnia is probably what most people in behavioral sleep medicine do, at least, to the majority of what they do. I would say for me, clinically, it's about 80 to 90% of what I see in my clinic. This is actually a paper that came out a couple years ago. It was put out by the American College of Physicians. And what's notable here is it's put out by the American College of Physicians, not psychologists, not APA, but, physicians here have said that, recommendation one, sorry, you might not be able to see it too clearly here, but that the ACP recommends all adult patients receive cognitive behavior therapy for insomnia as the initial treatment for chronic insomnia disorder. And this is a strong recommendation. So they're saying this should be the first-line treatment. Recommendation 2 actually speaks of medications, and it says that you should only consider medications if you've discussed the benefits, harms, and costs of short-term use, and to add it only in adults with whom cognitive behavior therapy was unsuccessful. So it's a pretty weak recommendation for medication. And so this is really notable because, this is the ACP, just so you guys know, if you're not familiar with this, these are mostly geared towards primary care doctors. And these are the people that are on the front lines that typically see people with insomnia. So the message to them is, hey, you should be sending these people to get Cbt-I rather than prescribing medication. And so this is an important message. It's, and I think it's a big win for those of us in behavioral sleep medicine. It also means we need a lot more clinicians out there because we don't have enough clinicians to meet the demands of people who have insomnia. So about 20% of the adult population has chronic insomnia. So we do need people out there, and there's lots of jobs to be had. So that was a major, win for us. And just so you guys know a little bit about CBT, I should stop and ask, how many people here are familiar with Cbt-I? Okay, so it looks like some exposure here. Have you guys gotten training from your graduate programs or other places? Or how did you guys get exposure to it, out of curiosity? Okay. All right. So besides me, all right, so it sounds like maybe just sort of pursuing it on your own. Okay. So, all right. So, those of you who know a little bit about it, you probably know that, the Cbt-I is multi-component. It consists of sleep restriction. I don't particularly like the name sleep restriction, but the idea here is that if you reduce the time in bed, this is usually one of the starting points for helping people with insomnia, because most people with insomnia, they take what makes logical sense, which is casting a wider net, spending more time in bed, but that actually works against the way your brain regulates sleep. So that's one of the first things that we do. Stimulus control, these are these instructions of if you can't sleep, get out of bed. But the key point here isn't so much to get out of bed and so forth, it's to associate sleepiness with being in bed. So that's really the key point with stimulus control. And knowing when you're sleepy is actually not an easy thing, especially for people with insomnia. So that's an important part that I think is a subtlety that people that do CBT, people who are new or novices with CBT-I don't really pay attention to. Okay, so that's an important part of doing Cbt-I is to get people to understand what sleepiness feels like, which is different than fatigue or other states. Okay. Sleep hygiene, this is what most people know, but really sleep hygiene is a set of do's and don'ts that's generally a fairly inert or a small component of Cbt-I. And unfortunately, over time, sleep hygiene has generalized into some other CBT components, which isn't really what sleep hygiene is, but generally these are habits that are counterproductive for sleep. I oftentimes make the analogy as to patients that it's like dental hygiene, flossing and brushing. Those are good things for preventive care, but if you have a cavity, brushing and flossing isn't going to get rid of your cavity. So if you have chronic insomnia, following sleep hygiene probably isn't going to get you out of chronic insomnia. But if you have like an occasional sleep disturbance, then yeah, following sleep hygiene is probably a good thing. But depending on where you are in terms of your development of insomnia, it may not be enough. And that's one differentiation between somebody giving someone a handout of sleep hygiene versus doing a full course of Cbt-I. Cognitive therapy, I think this comes in a lot of different formats now. Traditionally, as I mentioned, Charles Moore developed this. That was sort of the Beckian approach of like taking someone's cognitions and maladaptive thoughts and beliefs about sleep and kind of challenging them. I think now, people have infused mindfulness and other things. Sometimes just education itself can have a bit of an effect here. And then relaxation strategies, we still usually do some of these. This can help out with some of the physical tension. And I find that sleep education is helpful because this sort of builds a credibility and a rationale. It kind of separates what we do in CBT-I and how it's distinct from other forms of CBT and really other forms of psychotherapy. Because, the idea, and one of the things I usually clarify is that, from my standpoint, the cause of your sleep problems isn't some unresolved conflict with your mother or your father, things like that. The approach that I take is quite different. It's grounded in the science of sleep. It's really helping to synchronize your behaviors with the biology of how we understand your brain to regulate sleep and wake. And so I think from that standpoint, it helps people understand what we're doing, and it gives some credibility to some of our components. Okay. Any questions about CBT-I? Okay. So empirical support, it's quite strong. So meta-analyses, generally moderate to large effect sizes, about 3/4 or so of patients usually derive meaningful clinical benefits from CBT-I. Usually this will be a reduction in sleep onset latency. That's what SOL stands for in sleep world. And in WASO by about 50%. The increase in total sleep time is a little more modest. It's about 30 minutes or so. So we're much better at eliminating or decreasing wakefulness while you're in bed rather than increasing sleep. And usually, that's one of the things. I would say it's both a cognitive and a behavioral technique, in that I get people to try to focus away from just trying to sleep more. And I say our first goal is actually to be awake less while you're in bed, because we can do more about that. Okay. And really what we're trying to go for is improving sleep efficiency. So, out of the time that you're spending in bed, how much of that is spent sleeping? And so if you reduce that, as I mentioned, that's one of the main things that we do. That is one of the things that gives us the best chance to squeeze out that wakefulness, consolidate your sleep. So that's, where our outcomes usually lie. And one of the main benefits of CBT-I is that the outcomes and the maintenance tends to be durable. Our gains are usually seen because people continue to apply these tools versus medication. If you don't take it, generally you're not going to be sleeping better. Okay, so that part's not rocket science, but the fact that these effects are more durable does give it an advantage over medication. Okay, so this is a meta-analysis that we did. I do apologize. It looks like some of the text isn't coming out quite as well on the screen. Hopefully you guys can see this more clearly out if you're online. But basically what we look at here is what are the effects of CBT-I on comorbid conditions. So we pulled together all sorts of comorbid conditions, both psychiatric and medical. I mean, it included things like chronic pain, cancer, a lot of psychiatric stuff with depression, substance abuse, and so forth. And generally speaking, the effects, are pretty good. It does have some effects on the other conditions. So not just can you treat the insomnia, but can you have an impact on the other condition? The other thing we did is look at some cutoffs that people have developed for response and remission. And so I have here the remission at post-treatment. Generally, CBT-I gets about twice the rate of remission as controls. So it does have a pretty strong effect there. But notice that even the controls, you get about 18% of the response. So the placebo response, for treating insomnia is actually fairly notable. So then this gets into just a little bit about some of the work I've done. So we have this, what we call MBTI, which is our mindfulness therapy for insomnia. We now have a book out for this that really is geared towards clinicians. This is really our treatment manual. This was part of a K award, a career development award I had, which was to do some initial testing on this. And so this book really is our treatment manual that we developed from that project. And so the idea of putting this book together is that we now have a product that we can go and train other people. So the next step is to try to have other projects and other ways to try to train people. One of the things that's kind of exciting is I actually had an opportunity to go to Singapore this past March, and they're actually very interested in doing MBTI there. They actually have this community-based program where they're delivering mindfulness-based programs to the community, and they actually want to do MBTI as one of them. That's kind of fun to see, like, how this is kind of spread. And they also have some research studies looking at this as well. So this is what our main outcome studies from from my career development award. And if you're interested in this, I can share with you the slide and even send you the paper. But basically, just the summary here is that there is pretty good evidence that mindfulness. So we compared MBTI as well as the standard MBSR. Both seem to have some effects for insomnia. A little bit of an advantage for MBTI. It wasn't statistically significant, but this was a pretty small scale study. We only had 54 people. It's only about like 18 or 19 in each arm. But it gives us at least some initial evidence of the clinical benefits of mindfulness and insomnia. And then these are just to kind of show you that we have some other papers. This one's looking at the effects on cognitive emotional arousal. This is really where we think that our mindfulness program really has some effects, trying to reduce cognitive arousal, sort of what, in insomnia, hyperarousal is kind of the main thing that seems to be driving the insomnia. So if we can give them some tools to kind of reduce that. And so this just shows that we are pretty successful at reducing that. So the work we're actually trying to do now is looking at seeing if we can extend MBTI to help people with both insomnia and hypertension. So we want to see if helping improve their sleep at night can also improve their blood pressure management. So we actually have this pilot study going on right now. And actually, we're still recruiting, so that's why I have this. And we're actually hoping to get maybe a couple more people. So I have this slide here. If you guys know of anybody, please send them our way. We're actually planning on starting a group in October. So if you can, the best thing to do, you can either let me know or you can direct them to this email, chimes@northwestern.edu. There actually is this online survey they can complete as well. So that's a URL for it. So if you want more information, let me know. I can send it to you. And if you can have them, let them know that we're probably just going to be recruiting through the end of this month. But we could really use your help there. So it should be a pretty fun study. And this is a really small pilot study, so we're hoping to get about 8 to 10 people. We have about 6 right now, and they're just going to get the intervention. So there's no control group. They're definitely going to get the MBTI program, and I'll be running it. So, so an opportunity if you know of anyone who might be interested. Any questions about Cbt-I, insomnia? So, that's probably the thing that's most well known that, in behavioral sleep medicine. Probably the second main thing that we do is helping people adhere to Cpap. So Cpap is the main treatment for obstructive sleep apnea. How many people are familiar with Cpap and some of the things? Okay, so it looks like this is a pretty sophisticated group. This is the gold standard treatment for sleep apnea. Usually, it involves wearing a mask like this, and it's, as you can see, it's not the most sexy or a comfortable thing to wear. And so adherence to using this is a major problem. And so, where behavioral sleep medicine folks usually come in here is helping improve CPAP adherence. So this is a place where, if you use a CPAP, in a sense, it cures your sleep apnea because it isn't a very efficacious treatment, but you could say that it is not as effective because in the real world, only about 40 to 50% of patients use it regularly. The average use is somewhere around 4 to 5 hours. I would say that's probably on the higher side. And so the reasons why people can't use this, it's not very comfortable. Some people might be claustrophobic. It's just sort of the irritation, just the fact that you're wearing a mask to go to sleep. This isn't the most comfortable thing. For some people, it's because you're not seeing a daytime improvement or an improvement in their daytime functioning. I mentioned it's not, all that desirable in terms of appearance. And sometimes it's, hard to remember. You're tired, you just want to go to sleep. Or if you travel a lot, you don't want to lug this thing around. So, these are a lot of things that that the patients tell us that they can't, why they can't do it. What's kind of interesting is over the last few years, Medicare has gotten involved, and what they decided to do is use sort of this quality measure of saying, look, if you're not going to regularly use this Cpap machine, we're going to take it away from you, right? And we're going to give it to somebody else who wants to use it regularly. So there's actually now sort of this policy benchmark that sleep clinics and sleep centers have to try to follow. So this has really ramped up the need to get people to adhere their CPAP. And because if they don't, then sometimes they either have to repeat the sleep study. It sort of creates a burden in the system. So there's a lot of costs that are associated with that. So in terms of the interventions, in the early days, there was patient education and intensive support. Sort of the more like, yes, you can do it, sort of glorified cheerleaders. Well, not surprisingly, that didn't do much, right? We had like non-significant or small effects. As health psychologists got into this, we started borrowing models from other areas of health psychology, things like motivational interviewing, enhancing that, really mobilizing patient readiness for change, to resolve ambivalence. That's been shown to help, increase, adoption of new behaviors in other areas. Social cognitive therapy, emphasizing self-efficacy, cognitive reframing, social support. There's sort of this interesting study where people use peer buddies. So it was almost like kind of an AA model where they paired a new user to CPAP with, sort of a regular user, and they sort of had them in these dyads as a way to kind of motivate that and have someone, coach them that wasn't like a healthcare provider, but, one of them, so to speak. And so that was a really interesting study by Parasomnias in Arizona, and I think they're continuing with that research. So I think that's a real novel way to approach this. But this is another important area, and I think part of it here is because there's some economic aspects tied to it that can incentivize people. So again, if you're interested in health psychology and behavioral sleep medicine, there are jobs for you to work for you. The parasomnias. So these are the more unusual things that happen during your sleep, sleepwalking, dreams, nightmares, these type of things. And these are the more mystical things. We don't see this quite as much in sleep clinics. But one thing I want to talk about, because this actually has pretty good empirical evidence, is imagery rehearsal therapy. Anyone ever done any of this work, like in the context of PTSD or anything like that? It's actually pretty neat. So, this is targeting nightmares. And the concept here is that nightmares are like bad habits. And so it increases the frequency due to repetition. Inadvertently, they're not trying to do this, but, at sort of a subconscious level, it does. So it's possible to eliminate nightmares by practicing new dreams to replace these nightmares. So it's important to think that, to tell patients that it's not thinking about dreams, it's actually using mental imagery that activates parts of our brains that can replace the nightmare. So you actually have to engage in the mental imagery. And so you want to practice this when you're awake, when conditioned arousal is lower, so that you can actually use your frontal lobe to help you control arousal and the emotional control centers. And it's self-directed, so voluntary control is involved in the practice of the new dream. So let me just sort of walk you through a little bit about how this works. First thing you do is you get the patient to choose a new nightmare to practice. Choose a nightmare to practice. So you get them to write down the nightmare, in first person. Then you ask them, okay, write down a new dream. And you can change it any way you want. You can change characters, you can change the ending, you can write an entirely new dream. You can do whatever you want, write it in first person, present tense. And you want to do a dream that is no longer disturbing to you. Okay. After they do that, then you ask them in session to just rehearse it. So you kind of give them a little bit of space to do this. Usually it just takes a few minutes. You just encourage them to really, recreate it, use all their senses, make it as vivid and visceral as possible, use all their senses. And you want to process with them a little bit after they do this, make sure they're not just thinking about their dream, that they're really trying to, enact it and really use this imagery rehearsal. Then the instruction is go home, practice a new dream, do it at least twice a day. It doesn't take a long time to do this, 3 to 5 minutes. So again, the idea is that, it's sort of like habit reversal. So they need to practice this continually. And it's important to never rehearse a nightmare, to just rehearse the new dream. And it's actually pretty effective. This is now a little bit dated, but back in 2010, this was actually the go-to behavioral recommendation for PTSD-related nightmares. At the time, prazosin was the recommended pharmacological treatment. Since then, this actually is a position paper that came out on the treatment of nightmare disorders. This came out just a couple months ago, so this is pretty new. But I think since then, what they've done, and you probably can't see this very clearly, but they said that for PTSD-associated nightmares and nightmare disorder, and the difference is that nightmare disorder can occur outside the context of this PTSD. So people can just have frequent nightmares and not have the other symptoms of PTSD. But image rehearsal therapy is now the recommended treatment. And the ones that, what they call guideline treatments. Oops, sorry. So that's recommended. The one here says it may be used. So that means it's sort of a lesser evidence base. They have things like CBT for insomnia, eye movement desensitization, that's EMDR, things like that. And there are some medications here. So those, are now sort of downgraded to sort of the second level recommendation. And then they also have some more specific recommendations for CBT and so forth within nightmare disorder versus PTSD-related nightmare. So I think, to me, this is an area that's actually gaining more attention, especially with the rise of PTSD and for the acknowledgement of that, both in like the VA population and also just with, other trauma outside of, vets. Okay, and then I want to talk a little bit about narcolepsy. So, actually, let me just go back. So this is sort of a picture that I think a lot of people have of narcolepsy. These are people who are like falling asleep on a job. It's this uncontrollable thing. It's usually not quite that dramatic. People with narcolepsy usually just don't fall asleep in front of you. They might, but usually it's more like kind of chronic fatigue, sleepiness. It's usually like not so much a sleep attack, but it just really drains your energy, and it's very unpredictable. So it creates this huge burden on people, and it has a very, very strong impact on their quality of life. They really have poor quality of life, really high rates of depression and anxiety. So I got interested in this area because our sleep neurologist a few years ago approached me and said, I've got these people, I can manage their sleepiness, but I have a hard time, dealing with the emotional aspects of it. Is there anything you can do? And I said, I don't know. I mean, there's no textbook on what to do with these people. So I just sat there and listened. That was the first thing I did. And I tried to pull some other things that I learned from chronic pain and other areas. And I thought, there could be a real need for this. So sort of the basics of narcolepsy, I mean, it's obviously characterized by excessive daytime sleepiness. Interestingly, people with narcolepsy can actually have some nocturnal sleep disturbance as well. So not like they just sleep, really well throughout the night. They actually can have some symptoms of insomnia. I've actually seen it, more recently where it can be pretty severe. So that's, I think, surprising to some people. There's some other symptoms here, sleep paralysis, the hallucinations. Hypnagogic hallucinations are having hallucinations as you fall asleep. And a cataplexy is a condition where you have a sudden loss of muscle tone, usually in response to strong emotion, usually like laughter, could be surprise. These are actually symptoms that are related to REM sleep that are intruding into wakefulness. Because what happens is during REM sleep, usually your brain shuts off your muscle tone. Okay, and the idea is that that's usually the stage of sleep when we do our dreaming. And so as a protective way, our brain shuts off our muscle tone so we don't act out. But what happens is that when that starts to intrude into wakefulness, we suddenly lose our muscle tone when we're awake. That's what causes a lot of these symptoms. And since REM is associated with dreaming, that's what also causes like the hypnagogic hallucination. So narcolepsy is a really interesting condition because some people say it's this REM instability that also bleeds into wakefulness and sleep. And people with narcolepsy usually get REM very, very early in their sleep. That's actually one of the biomarkers of narcolepsy. So anyway, just so you understand a little bit about narcolepsy, there are effective treatments. Most of them are medications. I say all of them right now are medications. So sodium oxybate is Xyrem. That is actually what's used in a lot of the date rape drugs. So it gets a really bad rep, but it's actually a very effective treatment for narcolepsy. And as you can imagine, it's very, very tightly controlled. So it comes from one central pharmacy. There's all sorts of things that are involved in regulating it. But, it is actually fairly effective for people with narcolepsy, mainly because it helps improve the excessive daytime sleepiness, and it can also help to manage the cataplexy. And part of the mechanism that we think it works is because it helps to consolidate sleep at night. So it's an interesting drug in that it can do that, but at higher doses, it can, and used in evil ways, it can certainly have, a lot of adverse effects. And then stimulants, modafinil, armodafinil, this is Provigil and Nuvigil, and then methylphenidate, you guys probably know that, that's Ritalin. These are also common stimulants that people use. So, anyways, just to kind of move forward with this a little bit faster, the main issue here is that there's this unaddressed need at the bottom for in the psychosocial impact of narcolepsy. I kind of alluded to this. Here's a study by Mary Capella at UIC, just down the street, University of Illinois Chicago, where they found that this perceived stigma is really a main driver of depression. Mainly because people think of narcolepsy as being this funny thing, or people who are just like I showed you in that cartoon, falling asleep all over the place. So people with narcolepsy oftentimes have to deal with this when they're trying to explain that, oh yes, I have narcolepsy. Oftentimes they're met with like jokes, or people are like, oh, I wish I could sleep like you. It'd be so great to be able to sleep whenever I want to. Well, no, this is actually a very troublesome condition and has a very negative effect on your level of functioning. And this is a study where they looked at some of the burdens of having narcolepsy. Again, it's kind of hard to see, but what I'll point out here, and I'll sort of say it out loud, is that the rates of depression. So here, I mean, this is a match with controls here. So the rates of depression of people among people with narcolepsy is close to 50%. This is half the people with narcolepsy have depression versus about 26% in the general population. And most of these, like with bipolar, it's 14.2% compared to 4.6%. Anxiety disorder is 40.7% compared to 17.7%. So you can see that the prevalence of these psychiatric disorders is about 2 or 3 times the rate as it occurs in the general population. So really, really high prevalence of psychiatric conditions. Sometimes, especially with depression, it's a little bit hard to distinguish things like energy, low mood, how much of it is the symptoms of narcolepsy, the fatigue and so forth, how much of it is caused by an underlying depression. But I think, even across other conditions like anxiety, that shouldn't overlap as much with the symptoms of narcolepsy. This is pretty profound. So how can behavioral sleep medicine help? Well, I think there's an opportunity to really develop and borrow some of the other, behavioral sleep medicine treatments and other things that we've learned in other areas, like I mentioned, coping with chronic illnesses, to help people improve quality of life, improve self-efficacy, self-esteem, self-image as well, things related to health-related stigma. We've actually just run a focus group. We've sort of completed a study, I should say, in running focus groups, where we really heard a lot about people with narcolepsy, what they're going through. Some people have talked about things like not being able to have kids because they weren't sure that, they could deal with the sleepiness that comes with being a new parent, but also could they effectively take care of their kids. They don't want to be falling asleep with their kid, needs their attention, things like that. So they have actually set aside or deferred having kids. So this really has a tremendous impact on people's lives. Part of what we're trying to do is develop this CBT for narcolepsy in some different ways. I'm actually sort of taking a two-pronged approach. I have, one sort of line of work looking at developing a CBT for narcolepsy, another one looking at a mindfulness-based approach and using some things we've learned from mindfulness to help with emotion regulation and enhancing some of that self-esteem and self-image. But either way, our thinking is that these should be adjunctive treatments to their standard care. So one thing that's different with CBT for narcolepsy, or even mindfulness meditation is it's not meant to be a substitute for their standard care. They should still take their medications, but that manages their symptoms of narcolepsy. This is something that's really more like what we do in psychosocial oncology. It's to help people cope with, the diagnosis, the management of treatment associated with cancer. That really is meant to be an adjunctive treatment here. At least that's the vision that I have. But I think it's another opportunity for psychologists and behavioral sleep medicine folks to really play a role in, what's really a very debilitating condition. And I would say, it's actually pretty fun to work with this group because these are young people. The average age of getting diagnosed is somewhere between 15 and 25. And so these are, young adults, adolescents. They're usually very bright, very smart, and so they're fun to work with. And they all saw their lives going this way, and then suddenly they had these symptoms, didn't know what was going on, and now they see the life going this way. And so it's really, an opportunity to come in, work with people at kind of like an early stage where I feel like we can really make a difference. And so we do have a study where it's actually a pilot study where we're trying to do a treatment development for the CBT for narcolepsy. We do actually have some flyers with this. This is our email is the link study at northwestern.edu. Link stands for Living with Narcolepsy. So if you guys get, either in your clinical work or, know of other people who might be interested in this study, the study that we have going on now that we haven't quite started recruitment yet, but we will probably in the next couple of weeks, is actually to deliver this 6-week, 6-session behavior treatment. It's either in groups or individually, and we actually have kind of an online arm and an in-person arm. So the online arm gives us flexibility even if people aren't here locally, because our focus groups are actually run online. We had a lot of success with that. Actually, the last focus group was fun. We had someone from Argentina, someone from the UK, someone from Canada, and actually the domestic folks, the US folks, we had 2 of them. So they were the minorities. But the online allows us to have wider outreach, and I think for narcolepsy, which is still considered a rare disease, allows us to really spread our wings a little bit more. Okay, so the last things I want to talk about. Okay, all right, good. So is pursuing a career in behavioral sleep medicine. So hopefully I've at least piqued some of your interest in behavioral sleep medicine. So first of all, where can you get training? The Society of Behavioral Sleep Medicine does have accredited training programs. I think we're up to 11 or 12 now. So we're expanding our training programs, and we actually have one overseas now. That was actually one of my crowning achievements. We have an international accredited behavioral sleep medicine training program in Taiwan. So actually on the other side of the world. And so there actually is a list. The website's at behavioralsleep.org. Most of these training programs offer training at the graduate level, so PhD and master's level, internships, like for example, Rush is one that has training at the internship level, and postdoc fellowship. So here, most of the training I've done thus far has been at the postdoc level. So that's a good place to look if you're interested in getting further training in behavioral sleep medicine. There's also opportunities for ad hoc training. Even if you're interested, in just getting some training to incorporate into your clinical careers, but maybe not interested in becoming a BSM specialist. There are certainly workshops. Again, the SBSM offers them. There's online ones, and then some of these associations, like the Sleep Research Society and the American Academy of Sleep Medicine. There's an annual sleep conference, so we now call it Sleep in the Year. So the one coming up this year, I guess next year, is Sleep 2019. It's going to be in San Antonio. It's going to be hot. It's in June down there. But they have a really nice trainee day. A really good resource for people who are interested in sleep. And then they also have workshops and so forth. So the sleep conference is actually pretty big. This has usually about 5,000 or 6,000 attendees, and it's very multidisciplinary. So it's quite fun. And it's one that I enjoy every year. I'm actually pretty involved in. I was on the planning committee for a couple of years, so it's a fun one. And it moves around. It's in San Antonio this year. It usually bounces around between Baltimore, Seattle, Philly, Boston's another one. They're usually pretty large cities where there's sort of this, at least a mid-size conference center that can house about 5,000 or 6,000 people. So that's one way you get training. And then with that, so we do actually have a board certification now. It's called the Diplomate in Behavioral Sleep Medicine, the DBSM. This is actually brand new. We used to have what was called the CBSM. This was a certification in behavioral sleep medicine. So that was around, I think, from about 2004 through about 2014. And then we discontinued that because we were trying to pursue some other credentials. We actually tried to get an ABAP. Subspecialty through ABAP, but it actually got rejected. So we felt a little bit burned because we got the specialty designation by APA. Turns out, I think ABAP and APA, there's some political issues. But anyways, without going into it too much, we ended up coming back and doing our own certification. So this was just launched this past summer. We started accepting new applications for this Diplomat in Behavioral Sleep Medicine. So for people who have the old certification in behavioral sleep medicine, there's this holder application that allows you to basically provide your credentials. You have to demonstrate some continuing education in behavioral sleep medicine or sleep that allows you to be eligible for this new DBSM. and the oversight is provided by this independent board, which is called the Board of Behavioral Sleep Medicine. The website is there, bsmcredential.org, if you want to get some more information. And then finally, my tip, and I think this goes not just for behavioral sleep medicine, but really for anything, is find a good mentor. You met some of my mentors along the way, so hopefully you guys have some good mentors, and definitely talk with them. If you're interested in behavioral sleep medicine, I'd be happy to talk to you or connect you with other people in BSF. So like I said, we need you. This is actually an interesting thing where in our world, we have good empirically based treatments. We just don't have enough providers to deliver them. So this is what I mean by, we have good tools. We need to connect providers and clinicians with the patients that we have so we can better serve them. And if, we don't have enough providers, then it's going to go to apps and electronic delivery. And so, hopefully we can get you guys interested in this so, you can help us out here. And as you can see, we only have about 300 people who are board certified, whether it's through the CBSM or the new DBSM. So we definitely need some more people. And there are jobs going unfilled. In fact, there's a place actually across the street from us, the Center for Sleep Medicine, which is not associated with Northwestern. But I know the person, a couple of the psychologists there, and he's always looking for people in behavioral sleep medicine. So anyway, the job prospects are good. So anyways, like I said, hopefully I've at least piqued your interest in this. I wish you the best of luck in your future endeavors, and be happy to take any questions.
Thank you, Dr. Ong. That was wonderful. We have 3 questions coming in from the interwebs. So the first question is going back to the Cbt-I and MBTI. How do you decide whether to implement Cbt-I versus MBTI, or can you integrate those in some way?
Sure. I'll talk to the camera since it's good. So it's a good question, and I would say right now Cbt-I is still the gold standard treatment. It has the most empirical evidence. I think that with mindfulness, besides the work that we've done, there are, I think, 6 other clinical trials that have shown that mindfulness can be effective. So I think the research base on mindfulness is growing. But right now, that's actually one of the questions we need to answer with research, which is how do we make decisions of which patient should be? Is there a way to match treatment? Is there a way to kind of get baseline assessment and figure out who's a better candidate? I think theoretically we would say that someone who has high cognitive arousal, who's very anxious about their sleep. These are the type of people that we were thinking about when we developed MBTI and mindfulness-based approaches. With the Cbt-I, it's usually more kind of like a behaviorally based. And the cognitive work has more to do with people who feel the need to control their sleep. More of the maladaptive thoughts about sleep rather than what I would call metacognitions. That's kind of our theory behind where mindfulness comes in. It's helping people to sort of let go of the absorption of the problem. The sort of the attachment to the need for sleep, things that I would say falls under metacognitions rather than the thoughts themselves. So, that's our theory, but what we need to do is go and do some more research to try to answer that question of, who might be the appropriate candidate for which treatment. Yeah. So good question. Yeah.
The next question is, can you go over the best practices, recommendations, if they exist, for sleep medication tapering while going through Cbt-I? So this person said that they had heard that patients benefit from complete and immediate discontinuation of sleep medication, allowing them to rebound with their insomnia and then going through Cbt-I. They weren't sure if that's accurate.
Well, that would be a tough route to go. Usually what we recommend is that to do Cbt-I either before or concurrently while you're still on medication and then off. Because the idea is that, if you abruptly discontinue, you're going to have some withdrawal effects. So the person's going to be sleeping worse, at least for the first 2 or 3 days. That's usually where the rebound insomnia comes in. And so a lot of people just aren't willing to tolerate that. So that's a very challenging way to go. Also, depending on the type of medication, if it's like a benzodiazepine, it can be actually fairly dangerous to get someone to abruptly discontinue. You could trigger seizures and some other adverse events. So that's usually not the recommended route. I think that most providers prefer a more gradual tapering. So the idea is that we do CBT either before or concurrent to give them some behavioral tools and some other non-drug tools that they can begin to implement as we gradually taper or before we gradually taper them. And usually it's quite slow. It's usually over the course of like a few weeks. That varies a little bit depending on how much medication they're taking, like how many different types of meds versus their dose and things like that. Which usually we kind of cut down and then eventually introduce these medication holidays is kind of the general approach. One thing that I was taught that I found to be really helpful in doing this is to make an agreement that once you go down a level, whatever a level means, be it a dose, cutting down a dose, introducing an additional day in terms of medication holiday, whatever it is, you don't go back up. And the main reason for that is to try to reduce the contingencies and the psychological dependence. Because really, a lot of this comes down to how confident are you that you can sleep, that your brain can let you sleep, and that the pill isn't doing all of the work. And that's really what you're trying to do. You're trying to show the person that they can do it, and their brain can let them sleep. And the reality is that they really can, because sleep medications don't knock you out. That's general anesthesia. Sleep medications are facilitators, okay? But most people don't believe that. Most people can't wrap their head around that. They need evidence to do it. And that's really what the whole process is about. Okay?
And the last question was just, are there any books or manuals on Cbt-I or sleep in general that you might suggest?
Yeah, there are some good ones. Michael Perlis has a really good sort of step-by-step, like clinician's guide, like session by session. He's a first author. I think it's like Perlis. Don Posner's an author. And I want to say Carla Youngquist is one. But if you look at Michael Perlis, he's written a few of these books. So that would be one resource. There are some other ones. There's one that's actually like a principles and practices of behavioral sleep medicine. That one's a little bit more of a textbook that gives you, some more theoretical backgrounds rather than kind of like a clinician's manual. But I would say those are two good ones. And then there's tons of papers out there as well that talk about Cbt-I. So let me see, was that the question? Like, ones about Cbt-I? Yeah. So I would say start with those, and then maybe from there you might branch out, and that might lead you to some other stuff. I mean, I think if you just Google, look on Amazon and Google it, you'll also find quite a bit out there. I think the challenge is that there are some written for the layperson that is a little bit different than what would be appropriate for a professional. But some of those books for the lay people can be sort of like good accompaniments for treatment. Yeah. So, yeah. Mm-hmm. Yeah, so right, good question. So like for example, some people will think like I've got to sleep at least 6.5 hours or I'm not gonna be able to do anything the next day. Okay. And like I had one story I like to tell is I had somebody who actually had that exact thought. I think his number was 6 hours. And so one time actually just coincidentally we were going through CBTI and in between the time that we met for sessions we had daylight savings. And this was one where I think, we were springing forward, so he actually lost an hour, but he didn't realize it. And so what happened is that when he woke up, he thought he had gotten 6.5 hours of sleep. He went to the gym, he felt great and everything, but he realized that no one else was at the gym yet. And so, like, eventually, he was like an older guy, so there was like this kind of cohort of older people that would go to the gym at the same time. So eventually, like, his other cohorts came in. He was like, where are you guys? Like, why are you guys late? And they're like, what are you talking about? We're not late. Like, it's daylight savings. And then he realized that actually with daylight savings, he actually slept 5.5 hours. And after he realized that, he said the rest of his day sucked and he felt awful. And so I'm like, so was it really how much you slept or your perception of your need for sleep? And so people's perceptions of these things actually can matter quite a bit in terms of how they interpret their level of functioning, their sleep needs. So I would say that would be sort of an example. It usually has to do with the consequences, of their sleep. So sometimes it's sort of being really attached to a certain number. Other times it's sort of like rigidity with the regularity of sleep. Some people even get into rituals. I can think of another patient who was struggling with insomnia, then ate spaghetti for dinner one night and had a good night's sleep. So then she felt like she had to eat spaghetti, for dinner every night, or else she was going to have a bad night's sleep. So, so I would say one hallmark is rigidity of behavior. And that, I mean, in general, that's a hallmark of psychopathology, right? But especially with insomnia, it would be rigidity relating to something, that involves sleep or the consequences of sleep.
There's no, like, I mean, there's really no set number of hours you have to sleep per night, right?
Mm-hmm.
So if somebody is only sleeping a small amount of time, but they're not suffering any daytime consequences of sleep, do you treat? What do you do if that's a ridiculously low number, like it's less than 5 hours of sleep per night?
Yeah. So it's a good question because, technically, as with any DSM criteria, you have to have some associated consequence, right? And so if they don't perceive that they have a daytime consequence, then technically it wouldn't even meet criteria for an insomnia disorder or sleep disorder, right? So I think, one way to go about it would be to see if that's actually true. Like even if they don't perceive that there's like cognitive issues, are there other health consequences? Or the other thing might be, are they really falling asleep and they're not aware of it at times, things like that. So you do want to assess for that maybe a little more thoroughly. It might involve at times, a little more assessment, like giving someone an actigraph, an objective measure that can really take a look and see, are there like quiescent periods during a day that maybe they are napping, but they're not realizing it. Sometimes it gets difficult, especially for people who have chronic pain, who might spend a lot of time laying down. They just don't realize that they're sleeping. If someone truly doesn't have consequences, then yeah, I mean, for me, I don't necessarily push my treatments on people, especially if they're not going to be motivated to follow it. So, I sort of leave it up to them that, if you really don't have any consequences, maybe monitor it. But I sort of tell them, here are the things to look for, especially if you feel sleepy, because that's usually the main biological indicator of insufficient sleep, sleepiness rather than just fatigue. And maybe some other things like some memory impairment, some cognitive issues, and things like that. And if you start to notice those, then maybe come back and we can take a look at things. Yeah. Or I guess the other challenging thing is like if they have like a family member that thinks that they see some issues, but the person doesn't see it, then that gets even more. Yeah.
The person has reports no sleepiness during the day for years, reports sleeping about 2.5 hours per night, but is very disturbed that they're not sleeping more because they hear they're supposed to be sleeping more. And the same thing, we've been doubtful that they really could only be sleeping this little amount of time. Yeah.
The one thing you might want to look at is just, get an objective measurement of their sleep, whether it's with an actigraph or a PSG, polysomnography, because that'll at least rule out what we used to call paradoxical insomnia, or sleep state misperception. So that was a subcategory of insomnia where people's perception of their sleep is either it's very little or but objectively measured, like their sleep is, pretty normal, like 7 or 8 hours, or as close to that. Yeah. So so in general, people with insomnia tend to underestimate the amount of sleep that they get. This would be sort of a gross underestimation of that. So that's kind of the subcategory that we used to have. We've sort of taken that away, mainly because it didn't seem like having these subcategories mattered much in terms of how we treat people. And it didn't, if it didn't do much of that, then what's the point of these subcategories? All right. Well, thank you guys for having me. And thank you for coming out.